My name is Graham Warren. I'm the Vice Chairman for Research and a professor in the Department of Radiation Oncology, and I work with leaders internationally to try and address tobacco use in cancer patients. We've had the opportunity to work with several national organizations funded by NIH as well as other organizations and other countries to really try and help address tobacco use overall. Much of our work has been used in guidelines development and how to develop standardized assessments for cancer patients, trying to optimize methods to try and get people into cessation programs and help them quit, with the overall objective of really trying to improve our cancer treatment outcomes. The reason this is so important is because we know that smoking causes cancer across several different cancer disease sites. A lot of people have shown that, and a lot of reports have really demonstrated the adverse effects of smoking. But in 2014, we were really part of a group that really addressed the effects of tobacco in cancer treatment outcomes. What happens with continued smoking if people continue to use tobacco when they get their cancer treatment? The reason that addressing tobacco use is so important is that if we get people to quit smoking at the time of diagnosis, we can actually reverse a lot of these effects. We can improve overall mortality. As a matter of fact, we've shown that even using a phone-based tobacco cessation program, we're able to improve overall mortality by 44%. That's an astounding feat for getting people to change a habit, leading to improved cancer treatment outcomes. If we try and improve smoking, it's one of the best opportunities to improve outcomes for cancer patients as a whole. That fundamental aspect where we can really try and address one variable and improve outcomes for most all of our cancer patients really gives it a significant advantage, even over some of the most opportune targeted therapeutics. The 2014 Surgeon General's report showed two really important findings. It showed that smoking by cancer patients and survivors increased overall mortality, but it also increased cancer-specific mortality, which means that our first-line cancer treatments didn't work. And so we've been working for quite a while to identify how this affects cancer cells. And we're one of the few, if not only, labs that we're aware of that have really developed a chronic cigarette smoke exposure model in cancer cells. The unique aspects about this is that cancer cells are exposed to cigarette smoke throughout the week for several weeks, and then we look at how they respond to radiation or chemotherapy. From this, we've demonstrated that smoking decreases the effectiveness of radiation and all chemotherapeutics that we've tested for all cancer cell lines we've tested. Specifically, it's decreased the effectiveness of radiation and chemotherapy for head, neck, lung, breast, prostate, and colon cancer cell lines that we've tested in the lab, and we're extending it even further. The reason this is so important is because when we have patients who are treated with radiation or chemotherapy, if the effectiveness of treatment is decreased by smoking, it's critical to get people access to care specifically prior to or during treatment. We want to get them to quit as soon as we can. So Hollings Cancer Center and the Medical University of South Carolina have really been leaders in this area, particularly along the lines of developing standardized assessments and helping provide cessation support for not only cancer patients, but even patients across the entire MUSC enterprise. So with the initiatives that we're developing statewide, one of the things that we really considered was trying to use standardized guidelines for cancer patients. The National Comprehensive Cancer Network, or NCCN guidelines, now stipulate that all patients who use tobacco within the past 30 days should have access to evidence-based cessation support. The nice thing is that the initiatives we have here at MUSC and the initiatives that we're doing statewide with South Carolina really provide the same sort of access to evidence-based care. The program is developed around identifying tobacco use and using an individualized approach to cessation with state resources such as the Quit Line. So effectively, we're translating care using NCCN guidelines to our cancer patients statewide. When you think about addressing tobacco use in cancer patients, a lot of times people get lost in the weeds. But in reality, this is actually very simple. The biggest thing is to try and ask about tobacco use, and we have standardized assessments to do that. And then if you have people who are using tobacco, the nice thing about the initiative that we're working with South Carolina on is that you don't have to know how to provide cessation support. The biggest thing would be to just say, listen, smoking affects your cancer treatment outcomes. The best thing you could do to help your treatment outcomes improve is to quit smoking. We have resources to help you quit, and then get connected with the state resources or contact Hollings Cancer Center to try and help provide support. The nice thing is that we can provide cessation support without having to really burden the clinics. It's that simple. So this initiative really is an opportunity that we can streamline our clinical process, not add a lot of burden, and really provide evidence-based care in an effective and efficient manner.